Time for some clinical peanuts.
Uh, I'm presenting a case of 18-year-old female resident of Kaushambi, Uttar Pradesh, student by profession. She is having chief complaints of blurring of vision in both the eyes since last 13 years, along with the deviation of right eye since 13. Coming to the history of presenting illness, the patient was apparently asymptomatic 13 years back. Then she complained of blurring of vision in both the eyes, and the slight deviation of right eye was occasionally noticed by the family members since childhood. The patient or the attendant did not remember the exact time, but they were saying that around the age of 3-4 years, they have been noticing it, and she is using the glasses since then. The patient came for routine follow-up in the OPD, and she's coming every 6 monthly. And she doesn't have any visual complaints currently, and no deviation is visible with glass. So coming to the negative history, the patient does not have any abnormal head posture, any abnormal movement of the eye, and there is no history of precipitation of the ESO deviation with fever, no history of any other neurological event, and there is no complaint of diplopia. Coming to the past history, history of spectacle issues is present, which keeps on changing every year on an average. The patient is compliant with the spectacles. There is no history of uses of prism glasses, no history of any ocular surgery, and no significant family history is present. The birth history was uneventful. Coming to the general examination, the patient was conscious, cooperative, and well oriented to time, place, and person. A febrile, having pulse of 70 beats per minute. Coming to the ocular examination, uh, of the right eye, the visual acuity was 6 by 18 parts, and 8, and in the left eye it was 6 by 9. The best corrective visual acuity was 6 by 9 in the right eye and 6 by 6 partial in the left eye, along with the plus 3.5 diopter spherical and plus 1 diopter cylindrical at 90-degree axis. And in the left eye with plus 3 degree spherical and plus 1 degree cylindrical at 90 degree. The On doing the Hirschberg test, the CR was in the right eye, the esotropia of 10 degree was seen with care control. The ocular movements were full in all the gazes. The On doing the sensory examination first, or the on doing the Wordsworth dot test for the binocular single vision was present both for the near and the distance vision. While looking for the stereopsis, the nearest stereopsis by the lamp cards, 1200 arc per second was seen. On doing the alternate cover test, alternate esotropia with left eye dominance was seen. On film,
ये सब करते हैं
yes, ma'am.
Go ahead, go ahead.
On doing prism bar cover test, firstly for near vision, without the glasses, it was 20 prism diopter base out, and with the glasses, it was ortho. And for the distance vision, without the glasses, it was same 20 prism diopter base out, and along with the glasses, the patient was ortho. So these are the videos of the patient while doing prism bar cover test. Yes, ma'am. In the first video, while doing the prison bar cover test, we can appreciate there is deviation. But with 20 diopter prism base out, it is getting neutralized. In the video on the left, the patient is with glasses, and we can appreciate that there is no deviation is seen in the prism bar cover test. This
Okay.
is having normal color and pattern. The pupil is round, regular in reacting to light. The lens is clear, and the fundus is having the cup disc ratio of 0.4:1, healthy neuroretinal rim, and the foveal distress is present. On doing cycloplegic refraction with the homatropine drops, on the right eye, the patient is having the
How old is the child?
18-year-old.
Okay. And she has had these symptoms only since the past 5 years, right?
Since 13 years she's had, yes, ma'am, when she was around at the age of 5.
13 years. Okay. So she has this kind of blurring of vision and deviation of eye both since 13 years of age.
Yes, ma'am.
When did she start wearing glasses for the first time? Or was this the first time that she is going to be wearing glasses?
Uh, no, ma'am. She has started wearing glasses at that time only when her family members recognized that she is having some deviation. They came to the hospital, and at that time only she was prescribed glasses after a psychological reflection.
So what was her PGP? What was her
Uh,
present glasses that she was wearing?
Ma'am, at present she is wearing the plus 3.5 in the right eye, plus
Before,
3.5
when she
diopter.
presented to you, at that time also she was wearing the same glasses, or was it lesser?
No, ma'am, it was different. She was wearing plus 5 spherical in the right eye, along with plus 1 diopter cylindrical at 90-degree axis, and in the left eye it was plus 5 spherical and plus 1.5 cylindrical.
Okay. Okay. Go to the next slide.
Yes, ma'am.
Okay. To the next one, where you have done the cycloplegic refraction.
This is the cycloplegic reflection which was done at
Yeah. So the
this particular
cycloplegic
visit.
refraction, one thing I want you to notice, look at the cycloplegic refraction. So ideally, when you present a case, you should have all the refraction details on one page so that it's easy for reference.
Okay.
Here you should have your PGP, you should have your undilated AR, undilated refraction, retinoscopy if you have done it, and your dilated cycloplegic, which drops you have used. Okay, why you have not used cyclopentolate, why you have used homide, why you have not used atropine. Ideally, for any kind of accommodative issue, atropine refraction would have been better. Okay, so that is one thing. The second thing is the cycloplegic refraction here with homide. I'm assuming you have dilated homide, tropicohomide, or at least homide 3 times, waited for 45
Yes,
minutes
ma'am.
after the first eye drop, and then taken the refraction, confirmed that there is no accommodative activity that is happening. So that confirmation can either be seeing the pupillary reflex or checking with the retinoscope if there is a difference in dynamic retinoscopy. That is, if you are showing an accommodative target at a distance, taking it close to the nose of the child, and you see that there is no difference in the glow that is happening, then that means that there is no active accommodation happening. Okay. Um, one thing that I noted was that even though your cycloplegic refraction in the right eye was plus 5, plus 1 at 90 degrees, and plus 4 plus 1 at 90 degrees, what you have prescribed is under fogging, right?
Yes, ma'am. Yes, ma'am.
Yeah, so let's move on to the next slide where you have written what you have prescribed. Yeah, so BCVA you have given plus 3.5 plus 1 and plus 3 plus 1. So here is one thing that you need to understand. Let us go back to the basics of what accommodation means, what accommodative esotropia means, and why is this case a refractive accommodative esotropia and not any other kind of esotropia. Okay, so mm, don't feel pressured, but let us just have an open discussion. Even the others who are on the call are free to pitch in and help your colleague here. What stimulates a kind of accommodative esotropia? What are the factors that can cause an accommodative esotropia? So, can you give me a few examples? One of them is the patient himself. So, Pranjal?
And when the patient start looking for the near object and starts doing near work, then the patient try to accommodate. And as much as I have understood what does accommodative esophagia mean, so it happens mostly in the patients which are hyperopic. Uh, and when there is a blood retinal image, they are not using glasses, so blood retinal image forms on the retina, and they try to make it and make an effort
Fuse.
to make it
Yeah.
more clear, to fuse and make a clear image. So
Yeah.
in that process, they accommodate, and in that process,
That
they
causes.
accommodate, and while doing that, that causes convergence. So
Very nice.
hence
Very nice.
resulting into the
Very good, Pranjal. So your understanding is absolutely correct. You have used a few key terms. One is that peripheral blur is happening because there is some hyperopia. So mostly this occurs in children who have hyperopia. Generally, we start seeing these symptoms in children who are uncorrected hyperopia and just started going to school. Okay, so the ones which are 5 years, 6 years, 7 years, this is the general age group. It's a different story that we are seeing a lot of, accommodative spasms and accommodative esotropias in adults as well who are using a lot of near screen. But in general, this is how it happens. Hyperopia is one key factor. What is the other thing? Have you heard about accommodative convergence? AC by A ratio. Are you all aware about it? Pranjal, do you know about the AC by A ratio?
yes, ma'am.
Yeah.
Is actually when for a particular amount of accommodation when patient is using excess of convergence, so which results into the esotropia.
Yeah.
So accommodative esotropia can be the patient might have normal AC by ratio, A ratio, or it can be hyperaccommodative.
Yes, that's right. So, one thing is accommodation will always occur in conjugation with convergence. Convergence can occur irrespective of accommodation. Okay. So, whenever you are going to accommodate, the lens is going to move, the pupils are going to meose, and the eye is going to converge. ये तीनों होना ही है. Okay, so AC by A ratio is something that also affects accommodation, and it can also happen in children who have hyperopic correction. Okay, that is the second thing. So the first one is hyperopia, second one is the AC by A ratio, and there is something called as fusional divergence. Okay, so when your fusional divergence is low, just by the name itself, you can understand divergence means the ability to diverge. When the divergence is low, there is always a tendency to converge. Okay, so when your divergence, fusional divergence is low, and you're trying to accommodate and see an object, always there is a tendency for the eye to come inside. Okay, so these are the three factors. Most of them are hyperopic to start with. The second thing that we discussed is AC by ratio. How do you measure it? And like how is it significant when it comes to our treatment, Pranjal?
Measure it by there are three methods to measure the AC by rate ratio. The most commonly used is the gradient method. So what we do is we check the fringe power deviation for the near vision of the eye. if we are checking for the near vision, fringe power deviation, we will check. And then we will put the +3 diopter lens uh, with the best spectacle correction of patient, the
Okay,
cycloplegic correction.
very
And
good.
then
So first
again,
you
we will
put with
check the
the
deviation.
deviation. Yeah. So first you put the cycloplegic full correction, measure the deviation. Then you measure what is it with +3. That is complete relaxation of deviation. And then you divide it by 3 to get the AC by A. Okay. So that is how you do. The second method, the other method that can also be used and which is easier is heterophoria method. Okay. In that you measure the distance deviation, subtract the near deviation from it, and then divide by 3. Okay, so ideally the AC by A should be somewhere in between 3 to 5 prism diopters. So whenever this is not there, that is one time when there will be an accommodative esotropia with a high AC by A ratio. Okay, what happens in these patients is, this is for the others also to understand, that in an accommodative esotropia which is purely refractive and which has a high AC by A ratio, in those patients the distance squint will be much lesser than the near squint, at least a difference of 10 prism diopters. For example, if the distance squint is around 30, anything above 45 or 50, that is what the near deviation, that means that this patient is accommodating. Okay, many of the cases give full cycloplegic refraction. So this is what I wanted to correct on this slide is, you should have prescribed the full cycloplegic refraction. We always start correcting a patient who has refractive accommodative esotropia with the full cycloplegic retinoscopic refraction that we get. Okay, this is to completely relax the accommodation, because if the accommodation is not completely relaxed and it is just partially relaxed, what will happen is when we start weaning off the glasses, at that time again the esotropia will start setting in. So we should have started with +5 and +4. We should have observed for a period of at least 6 to 8 weeks, and then we should have thought about getting it lower. Also, if the child is younger in age and we feel that the fusional divergence will not be able to cover the excessive esotropia even after when we reduce the classes, we should wait till the child is big enough, maybe at least 9 or 10 years till you start weaning off if you have started at an earlier age. Okay. Now, in this slide, the other thing you have written is the Hirschberg's test. The Hirschberg's test, CR, right ET 10 degree with fair control. One advice would be, whenever you're presenting a case, please mention the full, the full form of whatever you're writing. Don't write CR. You should mention it as corneal reflex, or just write down Hirschberg test 10 degree esotropia with fair control. Okay. The ocular movements were full, stereopsis 1200. So one more thing to note is stereopsis will be fairly okay in these patients who have a purely refractive accommodative esotropia without a high AC by A ratio, and even the refractive error will be kind of moderate, something between 4 to 6 prism diopters, and it will be equal in both the eyes. Okay, anisometropia at times will also trigger some amount of accommodation in patients. So you have to give us full cycloplegic refraction. That is one thing. Okay, now if we move to a high AC by A ratio as well, you might have to give a cycloplegic eye drop, a stronger cycloplegic. One advice I would give is, for any patient whom you are suspecting has an accommodative esotropia, you should always do an atropine refraction, even if it's an older patient. Okay, because that will only completely relax and give the exact amount of exact amount of refractive error that the patient has, and then you can correct it accordingly. To start with, especially for adults who have sudden accommodative spasms or sudden accommodative esotropia, you can start them with eye drops like cyclopentolate or homide, and give bifocals along with it so that they can do their near activities. You can also give progressives if it's an adult. and slowly start weaning it off after at least 6 weeks of good control. Okay, so you can call them after 6 to 8 weeks, almost 2 months after the the accommodation is relaxed, and you see that the squint is not as prominent, and then you can slowly start weaning off the eye drops and then start weaning off the glasses as well. Okay, so you always wean off the eye drops first and then the glasses. How you wean it off is you start the dosing daily first, and then you make it alternate days, then you make it weekend therapy, and then you have to keep seeing them every 6 to 8 weeks, because that is how much time the brain takes in order to identify and start getting used to something new. So you start that, and on serial follow-ups, you can slowly wean them off the eye drops. And if you see that they are doing better, you can slowly start weaning off by 0.5 the near correction as well. For refractive accommodative esotropia without a high AC by A ratio, yearly around 0.5 will be what the normal eyeball axial length is going to grow and cause the refractive error. So around 0.5 you can start reducing after after a year of wearing glasses. So anytime that you see that the patient is coming back with the esotropia, please switch back to the older glasses. So what I generally do is I ask them to keep the glasses when I'm giving them a new refractive correction. I tell them to keep the old glasses till the time he gets used to the new glasses and there is no esotropia on the 6 week or 8 week follow-up. And then only we tell them to change the other glasses. Okay, so that is one thing I wanted to talk to you all about. The other thing is you all should also know how to check the fusional divergences, okay, that we talk about. This divergence and the fusional divergence and fusional convergence. What is it for distance? What is it for near? I'll just give a rough overview. Pranjal, would you like to say something about it? How do you measure the fusional divergences? What do you use? Just tell me what is the instrument that you'll use. Okay, so you use prism bars. Okay, so you use prism bars and you progressively make them look at a vertical fixation line, like we have the horizontal Snellens, like that. You can have a vertical line of letters on which they are supposed to fixate. And with the prism bar, you have to keep increasing or decreasing the prisms in order to see when they are fixing for distance or near for an accommodative target. When does the vision start becoming blur with which prism? When does the vision start becoming double with how much prism diopters it starts becoming double? And when does it become fuse and become single again? So these are the three things you need to note. When does it blur? When does it become double? And when does it fuse back? That is the recovery time. Okay, so all of this will give you how much the fusional vergence or the fusional divergence or the convergence or the negative fusional and the positive fusional vergence, how much it is, it will give you. That will give you a fair idea about whether he is falling into the normal criteria or not. In some patients, you might also have to give prism glasses. Okay, especially in patients who have a partially accommodative kind of esotropia. So now let's go to the third one. So we have already spoken about refractive accommodative. We have spoken about AC by A ratio. Now let us go to partially accommodative esotropia, in which despite giving the best correction after 6 weeks or 8 weeks or 3 months, when the patient comes back, there is still residual esotropia. Okay, so for these patients, what you can do is first you confirm that you have given the full correction by doing an atropine refraction. Despite that, if you feel that the refraction is still the same, then you can conclude that it is a partially accommodative type, in which accommodation is definitely playing a role, but there are other factors also to pay. So two things that you can do for these patients. First is give them a prism trial, give them prisms in their glasses, and slowly start weaning them off prisms if you feel that it is getting in good control. If that is not working, then these are the ideal patients for surgery. Okay, so squint surgery is what you can do. Now, when we come to squint surgery, we have two things that we have to take into consideration. Distance and near might be different. So what do we correct for? How do we correct these squints? If suppose the distance squint is 40, the near squint is 55, then what do we correct for? Do we correct for the distance or do we correct for the near? Pranjal, just guess. Pranjal is quiet or is she disconnected from the audio?
Others can also chip in.
Yeah, right. Whichever is low. Okay, so like we were saying, no, AC by A ratio is something we are considering. So of course, if it is low, then it is going to be a different type of squint. It's not going to be a refractive accommodative type of squint. Okay. Anything else?
So,
Okay,
Dr.
so this is
Surya,
a
I
very
want to know this. What about the role of these near point of accommodation and near point of convergence in these cases?
These
Do
are
they?
very basic
Okay.
tests. They are very basic tests when it comes to that is why I spoke about fusional divergences and divergences and so the near point of accommodation and all see of course because he is accommodating too much it's going to be too near. Okay, and the convergence is also you will see that the convergence is occurring at maybe 30 centimeters or maybe 20 centimeters. It's the convergence starts pretty early because they are over accommodating. Like I told you, accommodation, the neurological pathway is such that when accommodation occurs, the convergence is going to be stimulated. So that is also one more thing that you can do if you don't have prisms to check the distance and near. What you can do is you can check the convergence, how the patient is converging, and if you feel that the convergence is starting way early, then you know that there is an excessive accommodation that is happening in order to force this. So ideally, when you see that the muscles that are pulling the eye in are overworking, we generally do the medial rectus muscle. But here, when it is an accommodative esotropia, we do not touch the medial rectus muscles. We prefer to do a surgery on the lateral rectus muscles. Okay, and hence, because of that, most people are saying that the distance squint needs to be corrected, but no, the near squint needs to be corrected. That is the one that is causing the problem, right? So the near squint needs to be corrected. There are many people who just correct the near squint might get an exotropia for distance on the long run. But they try to keep the squint that is corrected in the range of below 10 prism diopters, completely not ortho, but in the range of 8 to 10, so that the fusion and the stereopsis and the binocularity still remains if the squint is between 8 to 10 prism diopters. Okay, so that is one thing. The other thing that they do is something called as a Fardin's surgery, posterior fixation suture, in which they put a suture on the sclera after the recession of the muscle is over. Then they put a suture on the sclera somewhere beyond the tendon of the muscle, so that distance squint is corrected, but even the near squint is overcorrected. That is, if you correct the squint for distance and near still has squint, when the eye tries to converge, that suture pulls it back, so the convergence becomes a little lesser. Okay, so that is one more thing that is done. Okay, I have a few questions here. After correcting near squint, will the patient not have diplopia for distance? No, there will not be a problem with the vision per se. Diplopia will not be there. The thing is, why we are correcting for near is the over accommodation that is happening, because the divergence probably of the patient might be a little better. He is not having as much squint for distance. Okay, so that's why we are correcting the near one. And generally doesn't have diplopia, but like the eye always has a tendency to drift out. So if you overcorrect at times, That is, if you have corrected and made him absolutely ortho, there are chances that there might be an exotropia for distance. That is why I said always undercorrect a bit and try to keep in the range of 8 prism diopters, so that the fusion remains with the glasses, whatever correction remains, and for distance the patient is ortho.
So if we have a patient where we are suspecting accommodative esotropia and we don't have the resources or expertise to check the fusional this, so can we take just the orthotropia as an endpoint of correction, or if we are
Yeah,
doing refraction and if the
yeah.
patient is
So
ortho?
yeah. So the main test in any of the, even the camp settings that we go to, if we don't have access to a lot of things, prisms are something that you should be having if you're doing a squint case. Okay. Hirschberg is something which can be just, just an approximate test. So you should either do the cover test and confirm there is no squint. With the best corrected vision, there is no squint. So the best cycloplegic, you have to complete full cycloplegic refraction has to be done with those glasses. After the child wears the glasses for around 2 months, when he comes back to you, there should be no squint on cover test. That is the end point. And once the child has worn it for over 6 months or so, you can start weaning it off a little bit according to what the cycloplegic refraction comes to. So every year around 0.5 of weaning is what we recommend. But at any point of time, if you feel that by weaning the squint is coming back again, then you go back to the old classes. And then you again wait for another 6 months to a year before you attempt correction again. One thing you should tell the patients is avoid near screen activity, avoid a lot of excessive reading and bad postures, take breaks in between, rule of 2020. Everything that we tell anybody who uses, who has computer vision syndrome or who is coming with a lot of problems related to the screen, that is what we would tell them also. Good posture, good lighting, for reading, especially for students who are, for children who are, having their board exams or entrance exams and all, who have to sit for hours together and who have esotropia, it generally tends to increase. One more disclaimer that I want to give you all, in case you all see patients with accommodative esotropia in your clinics, you might have their parents complaining after you give them glasses कि अभी चश्मा निकालने पे ज्यादा दिखता है squint. Okay, so once you give the glasses and the child's accommodation is completely relaxed, when the child removes the glasses, it is quite possible that the squint will be more obvious. Okay, so that is one thing that you all should be ready to counsel the patient before you give the glasses, that by removing the glasses, the squint might appear more for a little bit of while till the accommodation is relaxed. Okay, and you have to advise strictly for the child to wear the glasses 24 hours. I mean, like, except for the time when he's sleeping. There should be full use of glasses, because if you wear it partially, the eye is losing accommodation only for a little time, and the other time it is over accommodating. So your squint will never be corrected. Any other questions?
So this need for waning off is for risk of amblyopia or for divergence, or is it that because the eye is now going to accommodate less, like?
So one main thing is, if the child is smaller in age, you don't wean off so soon. They still have the capacity to, overcome the fusional divergence and all. But if the child is bigger in age, of school going age, you always run the risk of full cyclo. Like here we can see in this case, the best corrected visual acuity is 6.9 with plus 3.5. With plus 5, she was not seeing as well. So this is the reason. The reason is that we want them to have their full vision and have the capacity to have full stereopsis and binocular vision only by giving them 6.6 or 6.9, whatever is their best corrected visual acuity. For that reason alone, we have to start weaning them, even if their refractive correction shows, takes a year to get lesser. So you have to start weaning them off as soon as they start becoming ortho, so that you're giving them some scope to attain 6.6 vision. So in most children who are above the age of 6 years and have already attained 6/6 vision, their vision is not going to go back a lot. But you should never ignore the fact that amblyopia can set in at any point of time if full visual correction is not given. Also, you have to see to it that the esotropia is fully corrected. Otherwise, they start having monofixation, eccentric fixation, because there is a microtropia that is in play. So you should always do the 4 prism diopter test in front of the best corrected visual acuity also. Anyone has any more questions?
And regarding the need for surgery, if the correction is there with glasses, is there any indication for surgery?
No, absolutely not.
So even if the patient is in adulthood and he has esotropia after he takes off his glasses, we continue
So
with
here you can suggest one surgery, that is LASIK surgery. You can do a LASIK.
Okay.
Okay, so they get rid of the glasses. You can do a LASIK. You can also give a trial of contact lenses, and if he is absolutely corrected with contact lenses, you can tell them that we can go ahead with a LASIK. So if the girl is 18 years above, the boy is 21 years above, you always have the option of LASIK. In fact, LASIK, there were studies conducted if LASIK will prove beneficial in kids. And the studies were not very promising. So that's why we wouldn't advise any kind of surgery in kids, because their refraction is evolving. So, by the time they attend adulthood, they might go into myopia unnecessarily. So that's why for adults, that's an option. So LASIK is one surgery you can do.
I think there's a question for AC by A ratio. If you can
Yeah.
just brush up again.
Yeah. So the accommodative convergence, that is how much convergence is owing to the accommodation or trying to fix, versus how much convergence the patient originally has because of the medial rectus coming to the contraction. Okay, that is what is the AC by A ratio. So the normal AC by A ratio is around 3 to 5 prism diopters. You can measure the AC by A ratio by measuring the distance squint, subtracting the near squint from that, and dividing it by 3. Okay, so that will give you an approximate prism diopter number of how much AC by A ratio is there. More AC by A ratio means you have to give bifocal glasses. Okay, so in general, even without measuring it, you understand, because the near squint is 10 to 15 diopters more than the distance squint. That means whenever the patient is trying to see for near, he is obviously over accommodating. More squint for near. Okay, and there are more questions popping now. So AC by A ratio can be measured by two methods. One is you use the full cycloplegic correction, measure the near squint with an accommodative target. Okay. Then you add +3 to whatever correction you have given. Again, measure the squint with the accommodative target. Subtract B minus A, divide by 3. That will be your AC by A ratio. The other simpler method is measure the distance squint, subtract the near squint from it, divided by 3. That will also give you the AC by A ratio. Should be ideally between 3 to 5 prism diopters. If it is more than that, that means the patient has a high AC by A ratio. That means you have to give bifocal glasses. Ideally, executive bifocals should be given for children who are young and who will not know how to look through a D bifocal to see near things. Okay, give them executive bifocals. That is, it should bisect the pupil. The proper reading has to be taken by the optometrist or the optician, and you have to specify that they have to pass through the center of the pupil, because the child will invariably not know how to look down when he is trying to read a book or trying to do any near activity.
Ma'am, I have one question.
Yes, sure.
Ma'am, like in this patient, the psychophysical reflection is different, but the patient was on weaning, like almost like every year the point 0.5 diopter has been reduced. So
But
previously she was given the same with the cycloplegic reflection, and later on after 2-3 years, it keeps on we are weaning it. So is
okay,
it possible that we can the latent the patient gets good control and the latent hypertropia would have been compensating for it?
it is quite possible. But the whole point here is you have written Hirschberg test CR right 80 10 degree. Then how have you attained the aim here is to get rid of the esotropia. There should be no squint before you start weaning. It's as simple as that. If with the if with the old glasses the patient is having no squint, then you can start weaning them off. If the patient still had a 10-degree esotropia with fair control, then you cannot wean them.
The patient was having no isotropia with glasses, without glasses.
With plus 0.5 glasses, with plus the
Yes, on
plus
the
5 plus 5, with the plus 5 there was no, then if she was using plus 5 before, then it should have been weaned off only by 0.5, not by 1.5. Because from you
over
said
the
that the
time it has
PGP is
been built
plus
up.
5. Okay. So that is why I asked you what
PGP
the
is
last
plus.
PGP was. Yeah. If the last PGP was plus 5, then you should have made it plus 4.5. And any which ways, with the cycloplegic refraction being this, that means that earlier cycloplegic refraction, because the child must have grown, right? From 13 years to 18 years, the axial length must have increased and the hyperopia must have gone down. So if it is still coming plus 5 on cycloplegic refraction, that means previously maybe she was undercorrected.
Okay.
Okay, so the whole point is that whatever refraction you are giving, it should be able to, the full cycloplegic refraction should be given at the first go. And if the patient comes back to you ortho, then you can wean off by 0.5 after at least 2 to 4 months of using the glasses. Okay. And if it is in good control and weaning off is causing an esotropia again, then you go back to the old classes and wait for a year before you start weaning them off. Ideally, every year 0.5 can be weaned off. In accommodative refractive type, ET for both near and distance would be equal, but in accommodative non-refractive type, near would be more than distance, right? No, even in accommodative refractive esotropia, you can have a high AC by A ratio. It doesn't have to be a non-refractive type. It can be a plus. Somebody who has hyperopia can have distance and near issues. But also a non-refractive person who has a planar for distance can also have a high AC by A ratio. That would also be termed as non-refractive high AC by A ratio. So that patient can have distance planar and near plus 2.5 or plus 3 when you're giving the correction. Any more questions? Pranjal?
Oh, ma'am.
I think if we don't have any more doubts, then we can let Dr. Susha enjoy her evening.
Okay, thank you so much.
It was
Thank you so
really
much for
amazing.
having this session.
And, I'll say that the more we go into it, the more we realize that less we have understood about it. Because before this session, I was pretty confident about this. Now I feel that there's a lot more to it. So I would really
The
thank
biggest
you, Dr. Sushi, because You have given all the points, and it is really difficult to cover in so less time. And but it was really, you have made it quite simple, and at least in clinics or even in our this in medical colleges for the residents who have joined in, it will be really helpful when they come across this case, and they'll be, I think, be able to manage it confidently and correctly. So thanks a lot. And if any doubts, we'll again get back to you. Maybe just
Yes,
a
of course.
lecture on AC by A ratio.
Yes, of course. Of course. Feel free to reach out to me. You can contact Dr. Anuj if any time that you need. I'll send across my email ID. You all can send in an email with the detailed clinical history, and we can have discussions if you all have any doubts. Thank you so much for having me. It was wonderful. And thank you, Pranjal. That was a very nice case presentation. And I hope you all can confidently treat accommodative esotropia the next time you all see the patient in the clinics. Bye.
Anuj, can
Thank you so much, ma'am. Thank you, sir.
Welcome.
I think it's
Ekta.
someone was saying something.
hello?
Yeah,
Yeah, Anuj, can I say
yes, yes. So
something?
we have Dr. Une, who's a very senior faculty.
Oh, Vaishali ma'am is there.
She's
Oh.
the squint specialist, and knows about her. So
No, I would just like to appreciate. I don't, I mean, I just, so I was busy elsewhere, but I was listening to it and it was really very well done. So, congratulations to you and her both did very well. I'm sure the residents have benefited it. Thank you.
Thank you, Vaishali ma'am.
thank you.
So nice. I didn't know
It
you had
was so
joined.
wonderful. No, it was really wonderful. So I'm sure everybody's concepts have been cleared. Even mine got cleared.
ये ज्यादा हो गया.
No, it was really
Thank you
good.
so much.
Yeah.
Yeah. Thank you.
Thank you. Thank
Thank
you
you.
for joining. Next time we'll have you, ma'am.
I'm always there. Thank you. Yeah.
Thank you.
Okay. Yeah. Okay.
1 hour
Bye.
to 45 minutes.
Okay, so we'll shut down. Thank you, everyone. Thank you, Pranjal. It was amazing, and we'll catch up next with some other topic.
Thank you. See you. Bye.